Dr. Ravi Srinivasa is another professor from UCLA, medical school at Texas Tech, residency at William Beaumont Hospital, and fellowship at UPenn. And he will be giving us a talk on endoscopic biliary interventions.
All right. Good morning, everyone. Thank you to Nathan, Shreya, and Torin for the invitation to speak. So I'm talking about a topic that's near and dear to me as well here. So this is about percutaneous biliary endoscopy. So this has really kind of had a resurgence over the last few years. It's been around a long time, but I'm glad to see that more and more people are doing it, and hopefully you guys have been exposed to it in your training already. So we'll just jump right into it. So what is the scope of application for biliary endoscopy? So we're talking about doing percutaneous endoscopy here through an existing access, whether that's into the biliary tree or into the gallbladder. Primarily, we're using spyglass in the biliary tree for direct visualization of whatever may be causing a filling defect within the duct, whether that's a foreign body or a stone, or treating strictures sometimes in the bile ducts as well. We're also using it to perform kind of laser of strictures, and that's something that's potentially a new kind of method to treat patients with benign biliary strictures that have pre-existing biliary drains. So here's again a little summary of the different types of disease that you may encounter in the biliary system, hepatobiliary system. So the gallbladder, we treat cholelithiasis, we treat choledocholithiasis or stones in the bile ducts, and that may be in patients with native anatomy, but more often is in patients with surgical, post-surgical anatomy like hepaticojejunostomies or choledochojejunostomies that they underwent because of a Whipple or because of a liver transplant. And then the other thing that comes up in liver transplant patients is biliary cast syndrome, which occurs from having hepatic artery ischemia, where you basically the bile ducts slough. As you guys may know from anatomy, the bile ducts are supplied by the hepatic arteries. And so if you have impeded flow through the artery, then sometimes the biliary mucosa itself may slough and cause biliary obstruction in a liver transplant and can potentially threaten the survival of that transplant. And then identifying biliary masses, we've been able to biopsy and or treat patients with cholangiocarcinomas or intraductal papillary mucinous neoplasms in the bile ducts. So that's something that's also there. So with spyglass, things have changed over the last 3 or 4 years since spyglass has been around. In the past, we used to use reusable scopes, which were a bit annoying because there was a lot of setup to it. You had to borrow scope towers from the operating room, which was also in itself a challenge. But nowadays, with the Spyglass Discover unit, it's very simple, easy to plug, and it's plug into your existing fluoroscopy monitors and perform an endoscopic procedure. So we use a variety of methods for energy to treat stones and also to treat strictures. I typically use laser. EHL is probably the most commonly used method, and it's really easy to set up, and it comes with the system. It essentially uses a high voltage spark to cause energy to be transmitted into the stone and break it up, and you have a couple of different settings that you can use to break a stone or crack a stone. With laser, you have a little bit more configurability. You can really tune in as to whether you want to dust a stone and turn it into fine little particles or crack the stone into pieces. And depending on the energy levels, which you can see on this slide, you can achieve whichever goal. And you can even cut tissue. So if there was a scar tissue at a stricture, at an anastomotic stricture, you can actually use the laser to make an incision intracorporally, which is really pretty cool that we can do that now. So some of the benefits of SPY Discover is it's small, so it's not as big as some of the reusable scopes that we used to use in the past that were more like 16.5 French. Now this scope is is about 10 French, so you can put it through a 12 French peel away sheath. It's short, nice short length, so unlike the GI version of the Spyglass, which is called the DS, that one's a long one that goes through a transoral endoscope. This one actually just goes through a percutaneous. It's roughly 65 centimeters in length, so it's nice. It also has, a variety of articulation mechanisms, so you can really steer to wherever you need to go within the biliary system. It's also got on-demand jet irrigation, which also has been a game changer for us compared to some of the reusable scopes and even the older disposable scopes, because you can really get a pressurized irrigation of your bile duct to improve your visualization and also clear any debris or stone fragments back into the bowel. So I'm just going to jump into some cases here. So, and then I'll have a little bit of time for questions. So this was a 70-year-old woman with a type 1 choledochal cyst and had a Roux-en-Y-HJ. So this is your typical situation, post-op anatomy, and had choledochal lithiasis. So you'll see here as we scroll through the images, there's this large stone sitting within the biliary tree. And below that, there's a bunch of smaller stones as well. And so here, just another MRI image. And here's our access. We're just getting a central access initially, so you never want to take an access like this, so don't mistake this for being the primary access point, but we use this to opacify the biliary tree and then pick our target so that we can get now into the biliary system. So then we punctured a bile duct peripherally, got access and left a drain in, and then I think this patient was brought back a couple of weeks later to do the endoscopic intervention. And here you'll see us fragmenting this stone using laser. This is the laser with the little red dot, and you can really tweak your settings and get a really nice fragmentation of these stones. And so the best thing I found is to treat the stones that are the most distal first to kind of relieve the obstruction and then work your way back. And then as you clear the debris, you can start sweeping it with a balloon. So here's some more examples of sweeping or actually treating these smaller stones that were distal to that bigger one. And so that's how that works. And so then, yeah, use a balloon to sweep the stone fragments, and then you clear the biliary tree. So here you can see on the immediate post, and I always tell people this, including other faculty, that never trust your cholangiogram right after doing a biliary endoscopic intervention, because it'll always look kind of murky and mucky because you've just been instrumenting the duct quite vigorously. So usually just leave a drain in, put the patient on antibiotics, and bring them back. And so here you can see on the follow-up, it looks much better. There's no more stone within the biliary tree, and the patient did quite well. Here's another one, an 82-year-old woman, 82-year-old man with a history of cholecystitis, and he had multiple medical comorbidities, so he couldn't get his gallbladder out surgically. So here you can see this stone sitting in the gallbladder neck, and then also a stone in the cystic duct. So here we can be extraordinarily helpful. This patient couldn't get his gallbladder out surgically, and we have an option of doing a percutaneous intervention. So we have access through a cholecystostomy tube. You can see that gallstone there, as well as the stone in the cystic duct. And when we do a cholecystogram, you can see there's clearly obstruction here of the cystic duct, and this is consistent with cholecystitis. So we dilated the access. So in the gallbladder, it depends on the case, but on a case-by-case basis, I'll make a decision on whether to use the flexible small scope or use a larger rigid scope. Oftentimes, if you have a lot of stones or big stones in the gallbladder, using a rigid scope is a lot more efficient. This was just a small stone, but we still used the rigid scope nevertheless. So we removed that big gallstone, or the gallstone that was sitting in the lumen, and I don't have the images from that, but the images from the actual cystic duct stone removal. Here you can see us getting the spyglass right up against that stone. So we've got two wires going across down into the biliary tree. So this is essentially going through the gallbladder, down into the cystic duct, across the cystic duct into the common duct, and down into the bowel. And you can see our scope getting stuck right there up against the stone. And so here you can see us basically using the laser to fragment this stone and essentially dust it and treat it, and then clear out that stone debris. So here you can see the flyback after we've cleared the stone. So coming back into the common bile duct, the cystic duct now, and then back into the gallbladder lumen here at the end right here. So you can see that this is nicely cleared out, and then you can see on the final cholecystogram after a week or two after that procedure that the bile duct looks nice and open. So I think this was my last case here, 69-year-old woman with a history of a recurrent anastomotic stricture after a lap chole. She'd had multiple attempts at trying to treat this stricture with conservative means. So for benign biliary strictures, there's a lot of different ways that we use to try to treat them, using big balloons, or trying to dilate it with a balloon, trying to put in big drains for prolonged periods of time to try to open up these strictures. But none of these things work consistently. I'll say they do work from time to time, but they don't work consistently. So here you can see clearly this this hepatico J stricture that looks pretty severe. And so then we used laser to cut away the scar tissue. And so the nice thing about laser is you can see us using the laser here, and you can flex it and practice your cut. And right at the level of that stricture, sorry, I'll silence the audio here. Right at the level of that stricture, you can make a single radial cut and then treat the stricture that way. And then after ballooning it, it looks really nice on follow-up, and here you can see the follow-up imaging showing that stricture is nice and open, and the patient has been drain-free since then. So we're actually we actually completed a prospective trial of this at UCLA, and we enrolled, I think, 6 or 7 patients, and all the results have been very positive. So we didn't enroll a ton because we wanted to get at least 1 year of follow-up, and we have, I think, up to 2 years of follow-up on some of the patients, and there's been no stricture recurrences, which is nice to see. Here, just a last little thing here, using this to basically cannulate tiny strictures, and you can see us doing that in this case, where there's this pinhole stricture that we couldn't get across with conservative means, and here we can cross it with using spyglass. So it's really tight, tiny stricture. So so these procedures become much more easy using spyglass Discover. So that's all I got. If you guys have any questions, I'm happy to take any questions. Thank you, guys.
Excellent presentation. Thank you so much. We do have time for a couple questions if we could get those started, Nathan.
Hey, we have a question in the chat. How do you prevent choledolethesis and pancreatitis after you remove gallstones?
Yeah, good question. So, in my experience, actually, we when we go antegrade, I have seen much less pancreatitis. I know that there's been some discussion that there may have been a case or two that people did where there was pancreatitis that developed in a percutaneous case, but in our group, we have yet to see one. And when I was at Michigan as well, we never had a patient actually develop pancreatitis. I always put patients on antibiotics afterwards to minimize any chance of getting cholangitis or any sort of infection. But I think the reason, so when you look at the ERCP data, the pancreatitis incidence after ERCP is anywhere from 3% to 12%, depending on if the pancreatic duct is inadvertently cannulated during the ERCP. So if that happens, your risk definitely goes up if they end up cannulating the pancreatic duct inadvertently during an ERCP. And typically, if they do, sometimes they'll leave a stent in the pancreatic duct. But the way the pancreatic duct is oriented, it's very hard for us to cannulate the pancreatic duct going from an antegrade approach. Retrograde, it's possible, but antegrade, it's not so easy. And so I have yet to see any patients that developed it, but certainly if it does develop, you have to treat it accordingly. But the way I've kind of help convince myself that I haven't had any patients develop it is I put them on antibiotics, augmentin, typically for 7 to 10 days. Good question.
Next question is, once you treat a patient with cholecystitis and you remove the drain, do you put them on medications like Uros,
yes.
or
Go ahead. Yeah, so typically in any stone case, I usually try to get a fragment of stone as a sample to send for testing. So there's actually, at least in our system at UCLA, there's a stone analysis, and I think even in previous institutions I've worked at, I've seen an order for some semblance of stone analysis because the urologists use it as well. So you can hopefully order a stone analysis, and they can tell you what the composition of the stone is. If it's a cholesterol stone, then I think they may benefit from ursodiol. Otherwise, I don't know that there's any benefit. I know some patients develop side effects from being on long-term ursodiol, abdominal pain, and other things, and so it may not be necessary in every patient, but certainly there is some evidence to suggest that if you're on ursodiol in the setting of cholesterol stones, that it'll hopefully help prevent stones from recurring.
And one last question, what have your recurrence rates been after drain removal?
As far as stone disease, I haven't seen any patients have profound stone disease come back if you have appropriately treated whatever caused that stone disease to happen. So typically it's a stricture, or it's that the patient has, if they haven't undergone a sphincterotomy already, they have a stricture that's untreated. And if that stricture is left untreated, then it varies from patient to patient how quickly the stones would come back. But if you appropriately try to treat that stricture, whether it's using laser or putting a stent in or ballooning the stricture or doing something to try to relieve that obstruction, I think the chances are much less. There's certainly more data to be collected on this type of situation as to how to prevent strictures from occurring, particularly benign strictures, whether injecting steroids at the level of the stricture will help reduce inflammation after you cut the stricture, things like that. Will hopefully be presented in the coming years. But yeah, that's a good question.